Hello, good evening, everybody. My name is Alec O'Dare. Welcome to this evening's session, which is Managing Hard to Heal Wounds in 4 Simple Steps. Tonight's speakers are Angela Walker, who's the Podiatry Lead Clinical Specialist for Birmingham Community Healthcare NHS Foundation Trust, and the Wound Hygiene Ambassador. And we've got Maria Poole, who's the National Clinical Strategy Manager for ConvaTec. Maria, Angela, are you okay?
Good, thank you.
You can see that I giggled there a little bit because I was desperately trying not to call you Mariah for a moment. So that's what that was. Apologies just for the very start there. We weren't 100% ready, but we've obviously got you now. Tonight's session is brought to you in partnership with ConvaTec, so I'd like to thank them, in particular to Tim Frost, who I know has been working his socks off to get this event ready, along with Maria and Angela. So thank you very much. We've obviously taken a bit of a summer break, so we've not been with you for a few weeks, and we're really pleased to be back. I'm hoping each and every one of you has had at least a little bit of time off. Probably not many holidays between you, but at least hopefully you've had some staycations and you're all refreshed and ready to go for the rest of the year, because we'll be back with you pretty much every week until the end of the year. So we're looking forward to that. Links are going to be available for everything we talk about, including certificates, and you'll be able to download the presentation. If we don't get through to any of your questions this evening, we'll come back to you at a later date, put those onto a PDF. Apologies again, slightly thrown us. Maria, Angela, are you okay? I'm hoping that's just calmed your nerves now, and that any nerves that you may have had. Now we've gone through that, they're all gone, and you're ready to go. Angela, you're still on mute, so if you can just unmute yourself just for a moment. There you go. You're back with me. Maria, Angela, are you okay?
Still here, yeah, fine. Didn't go anywhere.
Brilliant. So without further ado, I'm going to hand you over to Maria. Maria's going to start the presentation. Angela and Maria will work on that. I'll see you back in a short while. Remember, do ask as many questions as you can, and I hope you thoroughly enjoy the presentation. Thank you.
Okay, so thank you, Alec, and I am going to extend another warm welcome to you all in case you didn't hear it the first time round, and thank you for choosing to spend your time with us here this evening. The learning outcomes for this evening's session are to understand the link between biofilm and hard to heal wounds, to recognise the need for early intervention, to learn about the wound hygiene concept, and finally to share the impact of wound hygiene in clinical practice. But before we do that, I'd just like you to take a moment to stop, to think of and to visualise a patient that you're caring for at the moment. A patient whose wound is potentially posing you some challenges. And their wound doesn't have to have been there for any length of time. As we'll hear from Angela, hard to heal wounds can be any wound that is exuding, that contains slough, that's increasing in size, and this can occur in as little as a few days of its occurrence. The key is recognising that these wounds are hard to heal and intervening early. So have you got that image in your mind? Can you picture that patient? Now hold on to them throughout this evening's presentation, because we truly believe, in the words of Pat McCluskey, another of our wound hygiene ambassadors, and formerly advanced nurse practitioner at Cork University Hospitals, what we're going to share with you this evening is something that is so simple, is easy to teach, and is empowering for staff to see the progress that hard to heal wounds can make by implementing these straightforward steps. So hopefully what we're going to share with you this evening will make a difference to that patient that you're thinking of in your thoughts and in your mind, but to many more patients too. So let's hear more about wound hygiene. So it's clearly documented in the literature that the number of hard to heal wounds is increasing. The associated economic and social costs are the costs to your patients, to their family and to their carers, and the implication for healthcare systems are posing a significant burden to all. Along with this, the management of wounds represents a high proportion of the usage of antibiotics and is a contributor to the antibiotics issues that we're all facing in our clinical practice. It's been suggested that wound care is in crisis and that a call to action to change clinical practice is needed. So with this in mind, in March 2019, the concept of wound hygiene first arose during an expert advisory board meeting. The advisory board were asked to consider two things: to consider clinical practice with regard to the lack of early intervention with biofilm-based wound care and the potential impact that this is having on the number of hard-to-heal wounds that we're seeing, and to consider a potential solution for this. So in July that year, an international panel was convened to discuss, develop and further define wound hygiene, its rationale and its processes. And in February 2020, the international consensus document Defying Hard-to-Heal Wounds with an Early Anti-Biofilm Intervention Strategy, known as Wound Hygiene, was published. Its objective is to implement the international consensus on wound hygiene and to embed real change in our wound care practices. And it represents expert opinion from 12 countries worldwide. Excuse me. So while it's well recognised that underlying patient factors will influence wound healing, and this is of paramount importance that we acknowledge this and we identify these and that we put measures in place to rectify them. It's also well recognised that biofilm is a key barrier to wound healing, and there's a strong and growing body of evidence that supports this notion. It's been demonstrated that over 78% of all hard to heal or chronic wounds will contain biofilm. And it's been suggested that biofilm are ubiquitous in hard to heal wounds, that biofilm are in all hard to heal wounds. So what is biofilm? There are many definitions out there, but simply put, it can be described as communities of microbes that attach themselves to a surface. Now, this can be a urinary catheter, it could be the inside of somebody's cystic fibrotic lungs, or as we're thinking of this evening, it could be a patient's wound. So once they've attached themselves to that wound, they embed themselves in a self-produced slime that then goes on to provide protection against antimicrobial agents and host defences, making it difficult to treat them. We also know that they reform quickly. They cause persistent inflammation, which can lead to wound infection and so hinder wound healing. So why are biofilm a problem? Well, we know that biofilm form quickly in wounds, and we know that they are difficult to remove completely and that they will reform quickly following attempts to remove them, thus keeping the wound in that low-grade inflammatory state and acting as a physical barrier to wound healing. They'll delay granulation tissue and granulation formation, and they'll delay epithelialization. And as we've heard, they're tolerant of the tools that we have in our toolkit. So they're tolerant to any antimicrobial dressings that we may use. They're tolerant to any systemic antibiotics that we may prescribe. And they're even tolerant to the patient's own immune system. So posing a real challenge to manage these microbes that are delaying wound healing in these wounds. So this evening, Angela's going to share with you the concept of wound hygiene. 4 simple steps to manage biofilm and progress hard to heal wounds. So step 1, to cleanse the wound. Step 2, to debride the wound. And don't think at this stage, debridement, I haven't got a competency for debridement, I can't do it, because that's absolutely not the case. Every healthcare professional and practitioner can deliver some form of debridement if it's just simply using a non-woven gauze swab to remove some of the debris within the wound right through to sharp debridement, and Angela will explain more about that as we go through. Step 3, to refashion the wound edges, where we know that biofilm tend to harbour and these microbes will protect themselves in this biofilm around the wound edges. And then step 4, to select an appropriate dressing that will be able to deal with any residual biofilm that's left within that wound and any microbes that have been exposed. So, as in the words of Pat, and it's something that is so simple to implement, it's easy to teach, and it's empowering for you and for your patients. If it's performed regularly and repetitively, this will heal your hard to heal. This will progress your hard to heal wounds. So hopefully you're all eager to know more about wound hygiene. And I'm going to hand you over to Angela, who's going to share with you her experiences of implementing wound hygiene in her clinical practice. Thank you, Angela.
Thank you, Maria. Good evening, everyone. Maybe from what Maria has said, or maybe on hearing about the wound hygiene concept, either tonight or over the past 12 months or so, maybe these have been some of your thoughts. This is really basic. This is really old stuff. We've always done it this way. It's just wound bed preparation. We've always done it this way. I'm not allowed to debride. I'm not qualified to do it. Hopefully tonight, you may start to think a little bit differently as we explore the wound hygiene concept that little bit more. So when we thought about wounds over the past few years, these may be some of the terminology that we've used, and maybe this has been a barrier to us in the way we think about how we manage them. And I think this is important in our learning as we move forward as well, how we think about the terminology. Maybe we thought of these wounds as complex, that maybe they were arterial wounds, maybe they're associated with underlying poor health conditions and other comorbidities. And maybe these complexities have helped stall the wound or even cause a failure for that wound to actually heal, leading to it being there for a very long time. But is it the wound that's complex, or is it actually the patient? A term used very widely by a lot of us for a good number of years is the term chronic, meaning that that wound is not healing or progressing, or maybe it's been present for a very, very long time. But maybe this has quite a negative connotation and almost a belief that it may naturally never heal. So thinking about this terminology, maybe we start to reframe this and we actually consider these wounds as hard to heal wounds instead, suggesting that they may be hard to heal, but it also provides a challenge for us to progress that wound to the healing. So when we think about defining a hard to heal wound, it's a wound that we said we may have considered chronic, static, or non-healing. But evidence tells us that a wound that has failed to respond to evidence-based standard of care is a hard to heal wound. And the concept here of wound hygiene is based on the premise that all hard to heal wounds do contain a biofilm. That means a wound that may exhibit a high volume of exudate, a wound that exhibits slough, it's increasing in size, or a wound that just simply has not changed. And also this evidence is telling us that by the third day of having a wound, if it's exhibiting some of these characteristics, it may already be defined as a hard to heal wound. So Maria has already talked about biofilm. We do think of it, of a biofilm, as what we actually see on the wound, that we see a slimy, shiny, sluffy surface. However, biofilm cannot be seen by the naked eye. It's microscopic. So therefore, we have to consider that if a wound is static and non-healing, without seeing any of these characteristics of slime, shiny surface and slough being present, that there may also still be a biofilm. So therefore, the wound hygiene consensus proposes that we have to assume that a biofilm is present in all hard to heal wounds. So in managing these wounds, it's imperative that we address this tenacious biofilm. So this brings us back to the steps of wound hygiene that Maria has already introduced: to cleanse, debride, refashion and dress. Most importantly, that these are carried out regularly and repetitively. This is demonstrated really well in oral hygiene. When we get up in the morning, we know that we've got a layer over our teeth and our tongue and in our mouth, and we want to clean our teeth. This biofilm is what develops overnight. So we may well then treat that throughout the day by cleaning our teeth, not just in the morning, but at other times throughout the day. If we didn't do this, then plaque will build up, and this is a major cause of periodontal disease. So we know from oral hygiene that using the right products and the method, we end up removing the biofilm that is there. And what we also do is do this repetitively and regularly. So we have a patient in front of us with a wound. The most important thing here to emphasise is that we assess that patient fully. We do a holistic assessment on them because we need to address any underlying etiologies with best practice care before we can actually start to address that wound. We may actually at this stage start to build a bit of a treatment plan. We then look in at the local wound, doing a wound assessment. We may have to at this stage as well think about, depending on where the wound is and what sort of wound it is, we may need to incorporate things like pressure relief into that as part of the whole treatment package as well. So when we look at the wound, we assess it, and then from all these things, we devise a treatment plan. That doesn't mean that while addressing any underlying issues and systemic issues with the patient, we can't start wound hygiene. They can be managed simultaneously. So let's go through each step. Cleanse. What are we doing when we cleanse the wound? We're actively removing contaminants from the surface, any debris, any slough, any remnants of previous dressings. But also we need to concentrate on the surrounding area of the wound where there also may be contaminants. We may well use to do this just gauze or non-woven pads, anything that is not going to leave any fibres in the wound as we cleanse over. And we may use cleansing or debridement pads and wipes, of which there's many now available to us from various companies, along with an antiseptic or an antimicrobial wash. Again, different products are available, or a surfactant, which may well already be within those cleansing pads. The rationale here is that whatever we're using, we're actually going over the wound surface and the peri-wound. And the wound hygiene consensus tells us to cleanse with intent, or I like to say it, clean it like you mean it. We do have to actively do something on that surface of the wound to disrupt any biofilm and contaminants that are there. So this firstly prepares the wound bed for debridement, but then secondly, it's cleansing the peri-wound skin, we're actually removing any dead skin, scales and callus, and removing any further sources of contamination around the wound. So let's think practically how we might do this then. When we cleanse over the wound bed, but then also we need to include 10 to 20 centimetres of the peri-wound skin too. Or think about it of the area that has been in contact with the dressing or the bandage or the cast or whatever you've got onto there. Areas where the skin can dry out, it can change, it can get sweaty and moist, and it can harbour contaminants and microbes within that area. We need to be cautious of preventing cross-contamination either from our environment or from the healthcare professional. So not to reuse any cloths, pads or wipes over the wounds of an area that we've already decontaminated. And this should be done with a force that the patient can tolerate. We do need to be actively working on that wound and the peri-wound skin. Again, regularly, repeatedly, but also based on assessment each time on the need and suitability for that patient that we're managing. So these pictures show this in action. In the first picture, you can see some shallow wounds, but you can also see around the peri-wound, we've got some scaling and crusting and dry plaques. These, even over healthy tissue, can be harbouring bacteria. So in the middle picture, we've got cleansing in action with a tool to actually cleanse it with some gauze or a pad and an antimicrobial solution. And then you can see the benefits of that in picture 3, where we can see the wounds a lot clearer. They're looking healthier wound beds. We've got rid of the contaminants around the area, and generally the peri-wound is looking much healthier too. So into step 2, debridement. Depending on what method of debridement you're using, it can be done in conjunction with the cleansing. If you're using a mechanical debridement pad or gauze with a antimicrobial solution, then generally you might be doing cleansing and debridement at the same time. But depending on the wound, you may choose a different type of debridement. You may choose sharp debridement with a curette or a scalpel, incorporating forceps and tweezers to actually remove as much tissue as you can from the wound or the edges and surrounding. It may be that the wound needs surgical debridement, which is a much more in-depth and deep type of debridement, which would have to be done within the acute setting. Other debridement techniques can be used with larvae and also hydrosurgery options too. So the idea here is there's a mechanical force and shear over the wound area in combination with your liquid surfactants and antimicrobial solution, so that we're actually breaking up and disrupting the biofilm. There is something important here, is to say that whatever you actually choose to use here is all within your scope of practice, what you were trained or competent to perform, along with the best method and choice for that particular patient. So when we're debriding, we're removing all unwanted materials, any biofilm, any devitalised tissue, any exudate, any sera crusts, any crusting that is there over healthy tissue that might be harbouring infection, any hyperkeratosis or callus. any debris, remains of dressings or foreign bodies that may be there. What we're doing is using a method that can actually agitate and disturb the wound surface to remove these unwanted materials. We didn't put in the list autolytic debridement previously. This is the use of de-sloughing dressings, because that won't manage this. Dressings alone are insufficient in wound hygiene. It's got to be part of the process of actually removing unwanted materials a bit quicker than a dressing will actually do, because this can take a long time with just a dressing. And in this time, it can increase the risk of infection if the wound isn't timely prepared. But we also need to know when not to debride. So if we're using active debridement, then it's certainly not recommended for those patients that are critically ischemic. These patients will probably be in a lot of pain anyway, and probably wouldn't want you to be doing that kind of thing to the leg. Any type of gangrene, wet or dry, or pyoderma gangrenosum, or any wounds that are associated with calciphylaxis and vasculitis due to the painful legs and painful wounds that's associated with it. But also patients who've got bleeding disorders who are on anticoagulant therapy, or some of those patients who just cannot stand the pain and they cannot tolerate whatever you're trying to use to debride. So we need to be very cautious of this. So therefore, we do need a full clinical assessment by a specialist to undertake and assess the suitability for a debridement method to be used on that patient, if at all, in some cases. And if the patient's wound is unsuitable, you should still cleanse the wound and apply appropriate dressing. There's still parts of wound hygiene that can be managed. So some tips here. Firstly is make sure that whatever you're doing and using is within your scope of practice. You don't need to, on a one-off debridement, take every bit of tissue off that wound. It can be a work in progress. And if you're concerned about how much to actually debride, then sometimes it's better to do a little bit of at a time. Remember, this is going to be a regular and repetitive activity, so you'll be coming back to it at another occasion. Any instruments or devices that we use for debridement must be sterile to prevent any additional contamination. And it's always a good idea after debridement to rinse the wound and peri-wound skin, ideally with an antimicrobial solution. Again, the debridement should be regular and repeated. There was a study of around 154,000 patients over a period of 4 years. They actually found that nearly twice as many hard to heal wounds healed with frequent debridement compared to those treated less frequently. And in fact, not just hard to heal wounds, but all wound types healed faster with frequent debridement. So here's a couple of pictures to show debridement in action. We're debriding here to remove all devitalised tissue and wound debris and biofilm actually on the wound bed, so that we can leave the wound bed in a better state conducive to wound healing. Don't forget, you might not get all the debris off at one time. Some of it can be left, it can be done at a later stage on another appointment. Please note here as well the pinpoint bleeding. Now, the wound hygiene consensus does tell us that having some bleeding, a pinpoint bleeding, is not a risk and can actually be a good thing. It's showing us that we've cleared the devitalised tissue or biofilm that has actually been removed, and it's restarting a healing trajectory. We wouldn't encourage everyone to say that you've got to make all wounds bleed, but some will bleed. So if it does happen, it's not a risk, it will heal. But you can see from picture 1 to picture 2, the difference there, not just in the wound, where we've got some bleeding and where the slough and the devitalised tissue has been taken away. But you can see in the satellite wound alongside it, the callus and the maceration around it has been removed because of debridement of the peri-wound skin and not just the wounds. So on step 3, when we refashion the wound, this is all to do with the wound edges. At the wound edges, you've got active microbes and bacteria that locate themselves there. So this is where biofilm becomes most active as it starts to form, and it prevents new healthy tissue. These are the cells that we need there to be healthy to facilitate epithelialization at the wound edges. So what we need to be doing is agitating these wound edges. We may get some pinpoint bleeding, but this is part of disrupting the biofilm and is a little risk, and it will regenerate as part of the healing process. So we need to promote and kickstart the cells at these wound edges to facilitate epithelialization. So as we start to refashion the wound edges, we might be using this in different forms of debridement again, maybe with our soft debridement pads or gauze and swabs even, but also sharp debridement. We need to be, with whatever tool we're using, agitating those wound edges, stimulating those growth factors and kick-starting the formation of healthy skin. We're removing devitalised tissue, and particularly callus that can build up around the wound edges, particularly on certain wounds, like on the plantar surface of the foot, where you get hyperkeratotic debris around them, and senescent cells that are old and inactive at the wound edges, which can harbour infection and encourage more biofilm formation. So our goal here is to facilitate epithelialisation and wound contraction. So some tips here. When you think about refashioning, the way to visualise this is to think about cliffs and beaches, and I'll explain this a little bit more on some pictures shortly. But if you've got callus and hyperkeratosis around the wound edges, it tends to make them thick and raised with a definite edge to them. This can harbour infection and can delay healing. In some wounds, you may get undermining, and under those edges, it may be that it is actually harbouring infection. And sometimes these edges may actually need debriding by somebody who can debride to that extent, or cut them away to actually allow the healing to take place, because we want to achieve healthy pink tissue at the wound edges. So here's the pictures about refashioning. In the first picture, you can see this is described as a cliff edge. It's a definite edge to the wound. There's a step there. And this will be even more noticeable if you've got hyperkeratosis and callus around the edges. In the second one, picture B, you can see that described more of a beach where there's a shallow and flush with the peri-wound skin. And then in picture C, you can see where there's a curette being used to actually remove callus and wound debris around those edges. Again, whatever you use on the wound edges is a method of choice for what's appropriate for that wound and within your scope of practice. So we come on to step 4 and actually dressing the wound and how we choose the dressing. With the dressing, the idea of what we're doing is that we're addressing any residual biofilm that was there or is still remaining after the previous 3 stages. We're preventing contamination and recolonisation, and we're preventing reformation of that biofilm. We know that biofilm can reform rapidly within 24 hours. So the work that we've done in the other 3 stages, we want to be putting a dressing on there to keep that going and to stop that reformation of that biofilm. But we also need to think about managing exudate efficiently as well to be able to promote wound healing. So the dressings that we choose need to contain an antibiofilm and antimicrobial agent to address the biofilm that may be there. Also a dressing that can absorb and retain exudate, and dressings that have a good wear time and are conformable and are comfortable for that patient. So the dressing choice needs to address residual biofilm, prevent recolonisation and reformation, and also manage the exudate level to promote the healing. So we know that most hard to heal wounds, or we have to presume most or all of them, are likely to have a biofilm. So therefore, using an advanced wound dressing is going to be most appropriate, because these wound dressings will have an antibiofilm property as well as antimicrobial property. We know that a lot of these wounds will be exuding, and this encourages the spread of biofilm and actually stops wound healing. It's a barrier to the healing of that wound. So therefore, the dressing should absorb and, most importantly, retain the exudate to protect the peri-wound skin. So we actually prevent the moistness going back onto the peri-wound to stop any maceration. So whatever dressing choice we choose, making sure that, particularly if we're using a primary and secondary dressing, that they are actually compatible to be able to do the work on the wound and the biofilm, but also be able to absorb and retain the exudate from that wound. So we do steps 1 to 3 to prepare the wound and address those barriers to healing. And then that puts the wound in a much better place for that dressing, that advanced wound dressing, to actually achieve its maximum efficiency. Some case studies for you here that you might be interested in. Pictures are always good, and they really do tell a story here. This is a case of a female patient. This is the anterior of her right leg. She had a catheter strap which caused an initial wound around her leg. So despite moving the catheter onto the left leg, she then proceeded to walk into the edge of the bed and injured at this area again. So this didn't heal. And although it was dressed regularly, this had actually been present for 7 months. So you look at the wound bed and you can see the characteristics on the wound bed of slough and devitalised tissue. And we assume because of these and because of it being long-standing that there will be a biofilm. So therefore wound hygiene was implemented at this stage. Cleansing with an antimicrobial solution, debriding, a mix of sharp debridement and mechanical pad. This was shared with the community nursing team, so they were able to follow this treatment plan. They were able to be able to do some part of debridement with a pad, and podiatry were doing sharp debridement with a scalpel. So whoever was part of that case could actually do some part of wound hygiene and debridement. The dressing choice initially here was Aquacel AG plus Extra, chosen because of its antimicrobial and antibiofilm properties and being able to absorb and work on that wound bed, along with the secondary dressing of Aquacel foam, both of them being well compatible together to absorb and most importantly, to retain that exudate from the wound bed and hold it to protect the peri-wound skin. So as the wound progressed, and you can see how well that progressed over that 5 and then that 8 weeks, there was a step down initially once the biofilm was managed to Aquacel Extra and then down to Aquacel foam alone. What is the key here was regular and repetitive wound hygiene, which progressed the wound quickly. In this case, this is the medial of the right foot. This is a patient who had diabetes, was neuropathic, had had vascular import in the form of an angioplasty about 12 months previous to this happening. It was initially caused by some shoes that had a Velcro strap, and the strap was tight and started rubbing and blistering, and then this wound progressed. This had been present for around 10 months. And due to her history, you would tend to label this patient as they will always have problems. There was numerous problems, had been going on, has been still. So we tend to have a bit of a negative approach to some of these patients who are quite complex. If you look in the first picture though, it's a good demonstration of the cliff edges to the wound. You can see a definite step in the wound edge. You can see maceration around it, and you can see the slough actually over the surface. This was very fibrous slough because it was long standing. So we implemented wound hygiene, shared again with the community nurse team, doing a mix of sharp debridement with antimicrobial solutions and pads. Initially, we used Aquacel AG plus Extra and Aquacel foam, and as the slough reduced and as the wound improved and we were seeing evidence of granulation, the maceration actually resolved, and you can really see that even just after 1 week of that treatment. Week on week, it progressed, and again, we used a step-down approach to Aquacel Extra and then to Aquacel foam alone. In this final case study, this is not so much a long-standing wound, it's more complex because of the patient's history and complexity. It was a fairly old gentleman, quite frail, with diabetes, was on dialysis 3 times weekly, and presented to us with gangrene and infection of the foot, which led to admission and surgical debridement. So on picture 1, you can see where there's the build-up of the thick, shiny slough and callus. That was 4 weeks after the surgical debridement. Looking at that, and you look at the characteristics there, you can see that this has the potential, if it's not treated right now, to become a hard to heal wound if it's not managed appropriately. So seeing this, you think we can't let this build up, it needs to be addressed at this stage. So implementing wound hygiene early here has had, I think, quite amazing results. So initially we used a debridement pad and antimicrobial solution with some sharp debridement to give the callus at the edges and where required, again shared with community nursing to share the care. Initially, Aquacel AG plus Extra, again with a step down. And actually, even after 6 weeks, it's a few weeks on now, that has completely healed. So what are the key messages that we might be getting from this? The importance of our full holistic assessment, addressing underlying etiologies before we start to actually look at the wound. That is important because there could be some barriers there to why a wound is not healing, and we need to address those initially. But then the importance of looking at our wound and doing a local assessment and formulating an appropriate treatment plan for whatever that wound is and wherever it may be. And thinking about early implementation of wound hygiene to cleanse, debride, refashion those edges and dress those wounds does improve the outcomes of the wounds, particularly if it is followed up regularly and repetitively. We do need to remember, though, that dressings alone are not sufficient to disrupt and remove biofilm. A dressing will not heal the wound. But a dressing with anti-biofilm properties as part of the strategy for disrupting biofilm and preventing biofilm reformation following the steps 1 to 3 is important. So appropriate dressing choice is imperative, and we can adjust it as needed as a step up and step down approach, again, based on our wound assessment and progression. And this is all based on your local wound care formulary, not just for the dressings you might use, but for the other products that you may use as well as part of this process. So what positives can we take from this? Wound hygiene can be very safely practiced by wound care specialists, but also by any general health professionals involved in wound care of all different levels. Think about it all within your scope of practice and what can be done as part of these steps. It can be used in any healthcare setting, such as hospital, GP surgeries, community settings and health centres, patients' homes, care homes and nursing homes. Wound hygiene is 4 easy steps to remember and implement: cleanse, debride, refashion and dress. Now think about the patient that Maria asked you to visualise at the beginning of this presentation. Is it a hard to heal wound? Does this challenge you to implement wound hygiene? Try it and see for yourself. Thank you. Ali, back to you.
I'm muted there. So there you go. There's another technical issue here this evening. Maria and Angela, thank you very much for a really good presentation. I've been looking at the comments throughout just to see how many questions we've got in. We've had many questions, which we'll get to now. Okay. Can I just start by saying, again, apologies for the technical issue at the beginning. We got to the bottom of it. It was a power cut at the office where our tech team are. So I do apologize for that. I've been smiling since you said this, Angela. I wrote it down because I just think it should just generally be a way of life for all things. And you said, clean it like you mean it. And I noticed another couple of other people actually picked up on that as well. I think it should just generally be the mantra for life in pretty much all situations. So I'm definitely going to remember that one. As we were running slightly late, I'm going to crack straight on with the questions, if it's okay with you two, because we've had quite a few of them. In. So the first one is for you, Angela, and the question is, how do I know how much to debride? I am worried about causing bleeding. Okay. I think choosing the appropriate debridement tool for whatever wound you've got is firstly important. And that, we must stress again, is within your scope of practice. So if you're trained with sharp debridements, use a curette or a scalpel, then you need to be competent and confident in what you're doing. And experience goes a long way with knowing how far to debride. So what I'd say is, if you're using something like that technique, then it's better to be cautious rather than go too far. But if you're using something like a mechanical debridement pad, then it still doesn't mean that you have to remove all the debris. You don't have to keep cleaning it and scrubbing away at that wound. You can just clean part of it, and it could be a work in progress to follow up next time. So not being frightened of any pinpoint bleeding as well, but not to be going too far as to cause any actual damage to the area. So I think the main thing is if with experience you would get used to knowing how much to debride. However, be cautious and take it easy instead and go step by step. Okay, thank you for that. Can I just take this opportunity as well just to ask in the audience, if you haven't sent in any questions just yet, please continue to do so. We'll get through as many of them as we can this evening. And as always, if we don't get through to any of them this evening, we'll compile a list of them. We'll share them with Maria and Angela, and then we'll create a document with the questions and the answers, which will go onto our website alongside a copy of the presentation and the slides from this evening that you'll be able to download. So if we don't directly get through to your question today, we will actually get through to it at some point. So please do keep them coming. Question number 2, this says that it's also for you, Angela. So this is, what dressings can I use to manage biofilm?
Okay, I think whatever dressing you're going to use, firstly, make sure it's within your wound care formulary. So wherever you work within your trust and local area, then it's worth looking at what choices are available to you at that point. I chose Aquacel products here, the Aquacel AG Plus Extra, because of its antimicrobial and antibiofilm substances, and knowing from practice that it works well. It is also on our wound care formulary. Talk to experts within your area as well as to what's available, and make sure that whatever you're using is evaluated as well within your area, firstly to be on your formulary, and secondly so that you know why you're using it, because we can be told about lots of dressings and the properties that they have, but we need to try things out, but we also need other people around us in trust to be trying them out with us as well to actually evaluate the products. So yes, there are other products out there to cleanse wounds and to prepare the wounds and to use as a dressing choice, but we do need to be understanding what wounds they are and what dressings we are using, and using them within our local formularies.
Okay, thank you very much for that. Maria, the next question is for you, and this is, if I'm worried about causing my patient's pain, can I give them essentially, or can they have an analgesic?
Absolutely, they can, and that should form part of the assessment. And in fact, something that we've been working on to support the wound hygiene concept is a patient information leaflet that clinicians can give to their patients to explain why suddenly we're starting to rub their wounds harder or cleaning it like we mean it, maybe more than we would have done, including the peri-wound skin, and explaining to them that this may be uncomfortable, but that we'll do it within their tolerance levels. And in fact, doing that assessment and getting those different types of analgesia in place beforehand to facilitate wound hygiene is a really important part of its success factor. So liaising with your medical colleagues or your nurse prescribers that can prescribe to that level, and ensuring that that patient is as comfortable as possible, but understands what you're doing and why you're doing it, and the fact that you will work together in partnership, that yes, it might be uncomfortable, but if they can just tolerate it for a little bit, they'll reap the benefits from it. And if it gets too much, then to say, you know, that's enough. And as to Angela's point, we always go back. It's always about that repetitive and regular and repetitive application of wound hygiene and the antimicrobial dressings after.
Okay, thank you very much. Question number 4. This is the question is redressing a wound with a biofilm weekly enough to combat it? So this isn't for anyone in particular. So how's about if I direct that initially to you, Maria, and then we'll see if Angela's got something to say about it.
I guess it's about individual patient assessment again, and looking at how that patient's wound is responding to that antibiofilm dressing. I think if the wound is progressing well, dependent on the levels of exudate, the size of the wound, the duration of the wound, etc., with weekly intervals, then you know there is no reason why you shouldn't continue with that. But I think at the same time you need to be led by the levels of exudate, particularly, and the way that the wound responds. If you're not seeing the results that you would like, then I would encourage more frequent dressing changes and more frequent application of the 4 steps, not just the dressing change side of it, but the 4 steps of wound hygiene to manage the symptoms that wound is presenting with.
Anything you want to add to that, Angela?
No, I think she said that. I think it is managing it on an individual basis for what the wound is and what the patient needs. Okay,
brilliant. We'll move on then. How would you advise to manage and treat Pseudomonas in legs? We have previously trialled most antimicrobials and in compression. Thank you. That's for Maria.
So my experience of managing Pseudomonas in legs really comes down to this, addressing the underlying etiology. Pseudomonas loves to live in warm, moist environments. And very often that comes hand in hand with when we see these very wet legs, these very congested legs that are leaking copious amounts of exudate. So it's about treating that underlying etiology, and if possible, getting them into some sort of compression or using a multidisciplinary approach to understand why the exudate levels are as high as they are, and to put measures in place to deal with those. So that really is the crucial part, because that's treating that underlying etiology. On top of that, then you would use antimicrobial dressings that are effective against Pseudomonas, and frequent dressing changes, but equally dressings that are going to manage that exudate, that will lock that exudate in and stop it from leaking onto the surrounding skin. But the key thing I would suggest here is assessing the exudate and identifying through investigation and diagnosing what's causing it, and putting measures in place to manage them.
Okay, thank you very much for that, Maria. The next question is for you, Angela, and this is wound cleansing a requirement for biofilm disruption before a dressing is applied?
Yeah, definitely. I mean, it's the initial step for actually wound bed preparation, because otherwise the dressing isn't going to work if that wound bed is not prepared properly. So you've got to be cleansing that wound to clear any contaminants that are there. Whether you actually debride on top of that, or whether that's incorporated in your cleansing with whatever debridement method you're using. But yes, this is all part of wound bed preparation, because otherwise the dressing will not work effectively how it's meant to if that wound isn't prepared properly.
Okay, there's a question that's come through which I actually saw in the comments. I will ask it, but I'm not quite sure whether you may be able to answer. I'll ask you, and then you can tell me. This is aimed at Maria. This says, can this be used on wounds in acute and emergency situations? And I saw there was a question in there which we'll certainly pass to you after the. So if you're the person, I do apologise if you're the person who asked this question, but it was a really interesting question about whether you do the same, whether it's the same methodology, the same sort of treatment, using the same dressings, if we're not necessarily talking about chronic wounds, but actually sort of emergency situations and acute situations. I think that's a much shortened version of what I thought was a very interesting and quite a complex question that came through earlier.
Yeah, and absolutely it can. You know, the principles will apply that, you know, if you've got an acute emergency situation that a wound has been sustained through some form of trauma, there's a very good chance that that wound is contaminated with whatever's caused that trauma. You may very quickly get high levels of exudate depending on what else is happening within that wound. So very quickly that wound is going to become complex and hard to heal. And the sooner you get these kinds of interventions into place with these types of wounds, whatever type of wound there be, in whatever situation, you know, the sooner that is, as Angela said, it's about local wound bed preparation really, and whatever contaminants are within a wound, whatever levels of exudate, they will all form barriers towards that wound healing. And, you know, as we said in the presentation, a biofilm will form a physical barrier. So you can put a really high quality dressing onto a wound, but if it's contaminated, if it's got slough in it, if it's not managing the exudate, and there's a biofilm in there, all of those things will impede that dressing's ability to do its job within that wound. So absolutely, the concept of wound hygiene, to cleanse, to debride, to look at the wound edges, to look at the peri-wound, whether it's lacerated because of trauma or because of, you know, just the length of time and the damage that's occurred to the peri-wound skin. They're all important steps that will help progress. And then, you know, all importantly, that selection of that appropriate dressing to deal with the symptoms that wound is presenting. So yeah, in short, I would say absolutely it can be.
Yeah, when you see that full question later, it's a really interesting one, because it immediately got me thinking that if you're talking about a real sort of trauma incident, if we're talking about, you know, a car crash or somebody falling off a mountain or whatever it is, then actually they're probably looking at more, looking at other aspects of the patient's whole well-being than just, right, how do we clean this wound quickly and stick a dressing on there to get rid of contaminants and things like that. But yeah, I'll share that with you. It's a really, really interesting question. So I thank you for
I'd like to add to that. I get what you're saying, Alec, but I think at the same time, if that wound isn't cleansed at that point, it's at higher risk of infection, and the consequences of that to an already compromised patient, potentially on a major incident type of scenario, could be quite a critical factor. So it shouldn't be seen. Yes, okay,
no,
obviously the life-saving actions are going to take the first thing.
I agree with you completely. I'm just saying that when we think about dressings, typically, we're thinking about the people who are choosing to put dressings onto patients are people who are often go in there to see them about a few things, but often go in there to see them about the wound. Whereas if you're in a sort of an A&E type situation, it's not always I have experience of this, personal experience, obviously. That's why I know that from a dressings point of view, while they were looking at other things, didn't really pay any attention to what dressing was being put on me. But that's a conversation for offline, perhaps, because that's a rabbit hole that we probably don't want to get into on this call. So the next question is, moving swiftly on, this is for you, Angela. Completely agree with wound hygiene. However, how can this be easier incorporated into self-care?
Okay, I think it's probably quite appropriate into self-care. That's where we're moving towards now, especially if you're using a cleansing agent, as in a wipe that's already got a surfactant that a patient can open and can use on their leg or foot themselves. Then that can be done, just teaching them how to do it. There's a lot of places using virtual teaching and education now for patients and supplying the dressing. So yes, it can be done. So therefore, with something like a surfactant already in a pad, you've already got the cleansing and debridement in there. So then supplying them with the right dressing as well, with regular reviews, and there's no reason why the patient can't be doing that.
Okay, brilliant. And then on to our final question. Is it possible to have this level of progress with no sharp debridement? We have no access to anyone with sharp debridement skills unless through podiatry for wounds on feet only. Also had a question about clinicians using curettage also, and competency is what that says. So I'm not sure. Let me just, it says, is it possible to have this level of progress with no sharp debridement? We have no access to anyone with sharp debridement skills unless through podiatry for wounds on feet only. I think the last part of that probably was a separate question, so I do apologise. So Angela, I think that one's for you.
Yeah, I mean, obviously it depends on where the wound is. I think we've said that already, really. Depending on where the wound is and what the wound needs, then you would treat it differently and within your scope of practice. But yes, I think some wounds can definitely be dealt with without sharp debridement. Yes, it might be better, might move the wound on quicker, but there's still other methods available as part of debridement to do that. When it came to a wound, particularly diabetic foot, where you have got a lot of callus, then chances are no, you're not going to be able to move that with a debridement pad. They would need some other type of debridement with sharp debridement and scalpel work. But for a lot of wounds on the legs, then yes, with using other mechanical debridement methods, then I'm sure, yes, that wound can move on quite rapidly.
Yeah. Anything you want to add to that, Maria?
I agree with Angela. I think any form of debridement, some form of debridement for these wounds is better than none. And if you can't do the sharp debridement, then, you know, the mechanical debridement is better than no debridement at all to remove the debris and what have you. To your point about curettage and competency, that's an ongoing debate, really. And some areas, and again, you have to look at your local guidelines to see what they are, but some areas will just teach curettage in-house. And people are just taught how to do it. It's a very simple procedure, very gentle procedure. Some trusts say that you have to have that level of competency to do it. I know that talking to those clinicians that can implement it, they just think, well, how do we manage before we could do this, because of the difference it's made to progressing these wounds by just very gently scraping off this barrier to healing, whether it be biofilm or whatever debris is in that wound. The impact that it's had has been huge for them. So it's something that I would certainly encourage people to, you know, if it's something that isn't implemented in their local trust, to go out and be the ambassador for that, to try and implement that change and take it as their quest to actually make their change in their clinical practice in their local environments. And certainly, you know, we're working to provide support, and we're working with clinicians that, you know, are teaching at a high level about curettage and things, and hopefully it's something we're going to be able to share in the not too distant future. But I would certainly, if I was a clinician still, I'd be taking it as my quest to make sure that patients have got access to this level of debridement, because, you know, it's almost like they have a right to it, really, the same as they do to having evidence-based best practice and best care. I don't know whether Angela would agree with that.
Yeah,
no, it's right. Yeah, I think, you know, we need to encourage all these steps to be used, and we need to encourage all these competencies to be out there. There's a lot of people in a lot of trusts who have got skills that can be shared.
Yeah, thank you. And shameless plug from us. We've got our first Wound Care Today event for the year. So this is our first live event. I'll be back on the 18th, the 19th and 20th of October in Milton Keynes, which is completely free to attend. So if you haven't already registered, please do so. And we have a curettage debridement workshop there for you to attend. And ConvaTec will be there. It'll be their first live event in over a year. So I'm sure they'll be looking forward to welcoming and saying hello to as many of you as possible. Angela, Maria, thank you very much for the presentation this evening. It's a really interesting topic. Apologies again, everyone, for the technical issue at the start. I think we managed to get over it, and most people are with us. So Maria, Angela, you probably want to know, we're pushing about 600 people watching this evening. I know you are keen to know how many people will be joining us at the start. Thank you again to the whole of ConvaTec, in particular Tim, who I know has been working very hard with Maria to get this all sorted. There should be some links on the website right now for both it's wound hygiene, all one word.com, where you can pick up lots more information from ConvaTec. They've got some amazing resources that you can download and ways that you can contact them if you've got any direct questions about anything that we've talked about this evening. And there should also be some links on there to be able to download the certificate for attendance. And don't forget, you'll be able tomorrow to share this link with any of your colleagues who didn't get to watch it. And in the next few days, maybe a week or so, we'll come back to you with any of the questions that we didn't get a chance to answer this evening. Thank you again for joining us. Thank you to my team for all your work this evening. Maria, Angela, I shall now let you go and have a nice glass of something cold. And I look forward to welcoming you back soon. And I look forward to seeing all of you join us for another event in the near future. Thank you and good night.
Good night, everyone.
Thanks. Bye.